Good morning. I'm Dr. Cavalli from the Internal Medicine and Clinical Radiology Department at Sarafella Hospital and University of Milan, Italy. And I'm here to talk to you about the heart and lung involvement in Erdheim-Chester disease. The slides to follow are a little dense. We had a lot of text because I thought you could keep them this way as a small compendium on this topic if you want to. Should anything not be clear, you can interrupt me right away. Heart and lung involvement affect, in a clinically evident way, up to 1/4 of Erdheim-Chester patients, as you can see in this graph on the left. And also, they're not particularly frequent manifestations at time of disease onset, but their frequency increases over time. As you see in this graph on the right, both manifestations reach peak frequency levels in the elderly populations. Another important feature is that these two manifestations often occur concomitantly, and they often reflect a high disease burden. This 1/4 figure of affected patient refers to those who are symptomatic. Silent cardiac and lung involvement is more common. Let's talk about the heart manifestations first. Virtually all heart structures can be involved in ECD, but some structures are affected more frequently than others. The single most frequent manifestation is the involvement of the pericardium, which is a thin membrane layer wrapped around the entire heart. Its involvement leads to its inflammation, which can cause the accumulation and collection of some fluid, which is called effusion. Alternatively, the inflammation can lead to the thickening or scarring, fibrosis of this membrane layer, which together with effusion can prevent the heart from regularly expanding to fill or contracting. Both these conditions lead to a situation called heart failure. When the effusion is particularly severe enough as to require urgent drainage, it's termed tamponade. Another structure that is frequently involved is the right atrium, as you see there, which is involved by a mass, normally a tumor-looking mass that is thereby called pseudotumor. This mass can expand, infiltrate nearby structure, compress them, and cause problems. The most commonly compressed structures can be the right coronary artery, as I mentioned before. This can lead to ischemia and myocardial infarction. Other structures can be involved are the interatrial or atrioventricular septum and the mitral valve, a valve separating the atrium and the ventricle. Its involvement by ECD may make this valve inefficient at separating both chambers and cause some spillage of blood back from the ventricle into the atrium, a situation called valve regurgitation. Finally, the heart muscle can be involved as a whole, which is called myocardium, and this may lead to irregularities in heart rhythm. The heart may not beat regularly, or can lead to a thickening of the heart and preventing from regularly and efficiently contracting to pump out blood, again leading to a situation called heart failure. Of course, in most severe cases of heart involvement, all these manifestations can concomitantly occur. What are your symptoms that should be indicative of heart involvement, that may require screening because of the possibility of heart involvement? Chiefly these that you see at the bottom of this slide: chest pain, shortness of breath, fatigue, cough, and palpitations. As for the evolution, as I mentioned before, cardiac involvement is not a very frequent manifestation of ECD at the time of onset, but the frequency increases over time, also because of this reason often reflects a high disease burden. Overall, 1/4 of patients have clinically evident cardiac involvement, symptoms due to cardiac involvement. And as for the survival, heart involvement has traditionally been considered a very severe manifestation, with a 5-year mortality of 30–40%. However, I do not think that this frightening figure is indicative of nowadays reality. First of all, we now have way more sensitive imaging techniques. We know that although heart involvement is more prevalent, more frequent than we usually used to think, in many cases it is silent, asymptomatic. There are truly life-threatening cases, but these are a minority. Moreover, with currently available therapies, we're able to tackle this involvement and to treat it more efficiently than we used to. And in our cohort of Italian patients right now, I do not expect, nor would I accept, a 5-year mortality of 30–40%. When and how to screen for cardiac involvement? I'm going to be quick on this topic because it's been extensively discussed by previous speakers. The single best modality for screening for cardiac involvement, the so-called gold standard, is gadolinium-enhanced cinecardiac MRI. It's a phenomenal technique in that it allows to take a short clip of the heart as it beats, thus allowing a very fine evaluation of all heart structures and of the function of the heart. However, unfortunately, it's not a widely available technique, so patients with ECD may, in some instances, still be subjected to suboptimal imaging screening techniques. These include transthoracic ultrasound, which is often used as a first-line imaging technique and has some utility for the detection of gross heart involvement or gross pericardial fluid, pericardial effusion. But it can underestimate the severity of heart involvement or may even not be able to detect it at all in some cases, so we should not rely on this technique. Another technique that can be used as an alternative to MRI, should MRI not be available at all, is CT scan, but again I have to stress that neither technique is optimal. When to screen for cardiac involvement? A complete radiological evaluation is mandatory in all patients at baseline, especially in light of the fact that heart involvement can be silent. And then periodic re-evaluations should follow, indicatively every 3 months after initiation of a new treatment, to timely evaluate whether our treatment is effective. And then, once disease stabilization is achieved, every 6 months to a year. And of course, changes in the clinical status, the onset of new symptoms, dictate the need for more urgent re-evaluations. When and how to treat cardiac involvement? Well, this is a very simple concept. All patients with heart involvement should be treated, and this should be done as aggressively as tolerated by the patient due to the risk of progression of heart disease and to the development of severe complications. There's many treatment options. Classically, traditionally, we used to treat cardiac involvement with interferon, administered at the highest possible dose, which ideally should be 9 million units 3 times a week. A more handy alternative administered once weekly could be pegylated interferon. However, the clinical response was highly variable. Some patients did not respond at all. One consistent thing, unfortunately, were the side effects, which were very frequent and burdensome. We explored as a center other treatments for heart involvement in ECD, which were promising before vemurafenib became available. These were infliximab or anakinra. Infliximab had an interesting mechanism of action in that prevented formation of pericardial effusion. Anakinra is widely used in conditions other than ECD, which is well known to decrease cardiac inflammation and promote cardiac contractility. But then everything changed since the arrival of vemurafenib on the market, and then other small molecule inhibitors which are entering the market right now. These drugs may allow to achieve stabilization or even regression of severe cardiac involvement. Why not treat all the patients with these drugs then? Well, simply because these are very toxic compounds, and the side effects, primarily cutaneous but also neoplastic, can be very, very severe. However, here is an example of how efficacious this treatment can be. On the left, you see an example of heart involvement encasing the right atrium, and after 6 months of treatment with vemurafenib, you see how this mass is clearly reduced. Let's move very quickly to lung manifestations. Similar to what happens to the heart, every lung structure can be involved by ECD, but primarily, again, some structures are very commonly involved. These include the pleura, which is a small thin membrane wrapped around the lung, and its involvement by ECD can cause its inflammation, with the formation again of inflammatory fluid called diffusion, or to its thickening or fibrosis. This can compress the heart and prevent it from regularly expanding. Alternatively, all the structures that account for the respiratory function of the lung, collectively called parenchyma, can be involved by a variety of different kinds of involvement. Here are two examples, but many more were shown to you in the previous presentation. You can have thickening of various structures, the formation of small infiltrates in the form of small nodules, or, as you see in this bottom image, extensive scarring of the lung, which leads to this so-called honeycomb appearance. The clinical complaints, your symptoms that may be indicative of pulmonary involvement, are chiefly cough, which is typically persistent and dry, shortness of breath, which is called in medical terms chronic dyspnea, or fatigue. Pulmonary hypertension, the involvement of the pulmonary arteries, is not commonly observed in ECD. And it should be noted that all these manifestations can also be indicative of heart involvement, which often is concomitantly present. As for the evolution, again, just like the heart involvement, pulmonary involvement is not very frequent at time of onset, but overall 1/4 of ECD patients develop a clinically evident pulmonary involvement. However, unlike the heart involvement, the progression of these lesions is not as worrisome. In the majority of cases that we follow up for a long time radiologically, we normally observe a stability or a mild, very slow progression of these lesions. And similarly, the impact of lung involvement in ECD on prognosis, on survival, is in comparison limited. A big study which compared the survival rates in a group of ECD patients with lung involvement versus a group of ECD patients without lung involvement did not detect significant differences in terms of survival rate. When and how to screen for lung involvement? In this case, high-resolution CT scan is the preferred technique, is the so-called gold standard for the evaluation of pulmonary involvement. It's very, very sensitive for the evaluation of whole lung structures. Conversely, plain radiographs are not useful at all in the evaluation of ECD. For the evaluation of lung function, we have a wide range of tests available, collectively called pulmonary function tests. These are widely available in any hospital and in most outpatient clinics as well, allow to evaluate the function of the heart, and we normally detect either a normal or a restrictive pattern with slightly reduced LCO, which means basically accounts for a reduction elasticity of the lung, a reduction in the capability of the lung to expand, to let air in, and a mild reduction in the gas exchanges. When to screen? Radiological evaluation, just like for most organs, is mandatory at baseline, even in the absence of respiratory complaints, because since we employ stably high-resolution CT scan, we found that lung involvement can be silent as well, and abnormalities can be seen even in the absence of complaints. Periodic re-evaluations should follow once yearly or earlier if clinically indicated. When and how to treat? In general, patients with pulmonary ECD should receive treatment. And unfortunately, the response to treatment of lung involvement in the majority of cases is only satisfactory. We very rarely observe a dramatic, really satisfying clinical response. The treatment choice should also be guided by the overall disease burden and by the involvement of different organs, but again, traditionally we use interferon at the same highest tolerable dose. Clinical response is variable, as I said, even more satisfactory than heart involvement. And again, the history changed since bimrafenib and other small molecules entered the market, which are indicated in most severe cases. So, in conclusion, clinically evident cardiac or lung involvement develop in approximately 1/4 of patients, and they are often concomitantly present. In many more patients, however, lung or heart involvement may be present but silent, or may develop later during the course of the disease. Thus, all patients should be systematically and periodically screened for silent cardiovascular or lung involvement with adequately sensitive imaging tool. And cardiac and pulmonary involvement are severe manifestations of Erdheim-Chester disease. This severity is highly variable on an individual basis, but nevertheless, the development of heart or lung involvement tends to reflect a high disease burden, and thereby treatment is indicated in all cases and should be aggressive. Thank you for your attention.